Hello, everyone. My name is Hermann Nabi. I am an assistant professor of epidemiology at the Department of Social and Preventive Medicine at the Faculty of Medicine of the Université Laval. I'm also a scientist and deputy director of the Oncology Division at the Quebec City University Hospital Research Center. My today's presentation is entitled BRCA Mutation Status, a transformative discovery for millions of women and men. What steps to travel the last mile? I will show you in a minute the reason why of the last part of my presentation title. But before that, I want to thank the Gairdner Foundation for organizing the Early Career Investigator competition this year. And special thanks to Dr. Mary Claire King, the Canadian Gairdner International Award 2021. Thank you, Dr. King, for your leadership, vision, and commitment. Thank you for the inspiration about science. You showed us the importance of multidisciplinary approaches and also the importance of bench to bedside and community research. Thank you for the opportunity. On the behalf of Dr. Tobias Karakach and myself, I want to really thank you for selecting us to be here for this event. My research program aims to generate evidence to support a responsible and equitable integration of precision medicine innovations fueled by genetics and genomics into healthcare and prevention, particularly for cancer. But for today, I will briefly introduce you the CMUGEN project, which aims to evaluate a collaborative model to make oncogenetics more flexible, accessible, and efficient. As you all know, the value of BRCA1 and BRCA2 genetic testing for risk reduction and treatment in breast and ovarian cancer is well established, thanks to the seminal work of Dr. King. However, after 30 years after this discovery, access to BRCA1 genetic counseling and testing remain challenging for patients and their families. This is due to the fact that the demand for these services actually exceeds this healthcare system capacity due to shortage of geneticists and genetic counselors. As a consequence, we are witnessing long waiting lists and delays, which is a missed opportunity for numbers of women and men. So alternative genetic service delivery model are actually called for. And one such model is the collaborative model, which differ to the traditional oncogenetic models, at least on three aspects. The first one is the team. In the collaborative models, the oncology teams, which include general oncologists, surgical oncologists, general practitioners, and nurse trained in genetics, and patient partner work with the medical genetic staff to convey different services to patients. A diverse and personalized service to patients, which include individual counseling, for instance, group genetic counseling, or also a different way to convey the result to patient, including by letter, if over the phone, or and also online due to the COVID-19 pandemic, for example, this year. And also there is an institutional collaboration and shared responsibility of the care of patient in a way that to make sure that they are integrated throughout the trajectory of the care. As a result, as you can see on this graph, the number of patients who receive a genetic counseling for HBOCC significantly increased after the implementation of the collaborative oncogenetic model at the Quebec City University Hospital in 2017. In addition, the average number of days between the counseling and the disclosure of the genetic test results significantly decreased as well after the implementation of the model in 2017. Last but not the least, patients were very satisfied with the whole process, particularly for group genetic counseling. And as you can see here, most of them were very were satisfied to very satisfied with the different aspects of these procedures. So what next? We are planning to investigate whether the collaborative oncogenetics model or some of its components could be applied to other healthcare facilities, and particularly in rural and remote areas that do not currently have access to a genetic counselor or geneticist. I'm also very thrilled and looking forward to collaborate with my new colleague, Dr. Tobias Karakach, on project aiming at integrating multi-omics data, which is the focus of his lab, in addition with clinical and epidemiological data, which kind of data we have here in my research group. So thank you very much for your attention, and I let Dr. Karakach pick up the presentation. Thank you very much.
Thanks, Dr. Nabi, for that kind introduction. Now, before I proceed, I would like to reiterate Dr. Nabi's sentiments in expressing my sincere gratitude to the Gairdner Foundation for providing a forum for us early career investigators to present our work, and to Dr. King and her fellow laureates for selecting the two of us specifically to present at this year's symposium, obviously from a pool of very highly qualified colleagues. Now, my name is Dr. Tobias Karakach. I am assistant professor in the Department of Pharmacology at Dalhousie University in Halifax, Nova Scotia. I'm also a research scientist with the Beatrice Hunter Cancer Research Institute in the Atlantic provinces. Now, my research program is referred to as the Integrative Multi-Omics Research Program in Pharmacogenomics. Now, what does that mean? It means that unlike Dr. Nabi's work, we use high-throughput bioanalytical technologies to obtain measurements of molecular descriptors of biological systems. So, other than looking at the clinical parameters, we're looking at the molecular measurements for these biological descriptors, be they humans or other model organisms. The general framework is exactly the same, where we start with hypothesis and design experiments that can test this hypothesis. Obviously, for us, we use these technologies, the mass spectrometers, high throughput sequencing, for those of you who are familiar with this lingo, to generate data. With this data, then we can infer information. One characteristic of the data that come from our lab is that they're very high throughput. In other words, we generate big data. They're not just high throughput in the sense that we get multiple measurements at the same time for many systems. We're also looking at a lot of descriptors, so coming up with what is truly big data. In my lab, what we do is we develop methods to analyze this data in order to come up with a small set or a panel of markers that can incontrovertibly answer the hypothesis that we have set out in the beginning with high specificity and high sensitivity. The caveat, though, is that without the clinical parameters, our sensitivity or our specificity is compromised on the molecular system. And that's why I say that the work is very highly multidisciplinary and data-driven. Now, having said that, I'm not starting this, my lab is not the first to do this. This type of work was actually the pioneering work of Dr. King through her career. And she's truly a giant upon whose shoulders we stand as we follow this paradigm in molecular biology research. Now, as I said, my lab is fairly new, but what is the ultimate objective? So the ultimate objective of our lab is to design chemotherapeutics or therapeutics that can be used to for targeted treatments. So targeting individuals based on their molecular profiles, so that we design therapeutics that are not one size fits all, but that are targeted to individuals based on their molecular profiles. How do we do this? We take a population of individuals, we obtain their molecular profiles, and by molecular profiles, we're talking about the DNA, looking at the RNA, looking at modifications to the DNA, proteins, small molecular weight metabolites, and to come up with an integrated panel of markers that can give us a prognosis for the conditions that we're investigating. We're looking for markers that are predictive of the sensitivity and resistance of these drugs, or markers that are predictive of adverse effects. I'll give you an example of one such work that we are doing with the children's cancers. My lab is currently focusing on a childhood cancer of the kidney, referred to as Wilms tumor. And with this type of data, what we are looking at, we're looking at differentially expressed genes. In other words, genes that are differentially expressed between kids that have tumors that relapse and those that have tumors that don't relapse. We're looking at copy number alterations. When we talk about copy number alterations, we're referring to, in this case, somatic mutations. So mutations to genes. So we've seen this. Dr. King has really done phenomenal work with the BRCA1, and we know the impact of BRCA1 and BRCA2 in predicting breast cancer. But we also add DNA methylation. In other words, changes to the genome that are non-mutations, so epigenomics. And of course, with that, then we get the triple evidence for functional characterization. An example of some of the results that we've gathered is, now if you look at the entire karyotype for this set of cohort of individuals, we can see mutations that are spread out through the karyotype, but we're looking for something that is systematic. So in this case, in chromosome 1, if we zoom in on this one chromosome, we can see this. We can see that there's a copy number deletion at a given location on this chromosome. And when you look at the expression of genes, we then see that there's a set of genes that are differentially expressed between the patients that relapse and those that don't relapse. And when we look at where they are mapping on the chromosome, they all happen to be mapping within this same region or within this same chromosome. So integrating that information in order to either generate new hypotheses or to validate our findings. Now, we can also go further and look at the epigenome and see that within the epigenome, there is a methylation at a specific location that is very indicative of the overall survival or the overall risk-free survival for these patients, and it's very significant. So, in other words, hypomethylation or hypermethylation influences an individual, or can tell you prognostically that that individual is going to have to relapse. Now, in a nutshell, here's what my lab does. So we take a fundamental bioinformatics, so we develop mathematical models. We use those models translationally, so we apply those methods to data from the lab, and we validate our findings with empirical methods, and then go back and develop methods to refine our workflow. Now, as I mentioned earlier, we want to get markers that are highly specific and very sensitive to the hypothesis that we are testing. What will increase those sensitivities is adding clinical parameters. So the Kaplan-Meier, for example, that I showed is a univariate measure. And we would like to add other parameters, say Cox proportional hazards models that can then incorporate these other measurements. And I thank my newfound collaboration with Dr. Nabi, facilitated by Dr. King. I'd also like finally to, once again, to thank the Gairdner Foundation for this opportunity, and to Dr. King for her vision and her commitment to helping early career researchers. And I thank you for your attention.